beautiful country, the stimulating scientific discussion yesterday, and really an interesting meeting today. I am tasked with this topic, so I'm going to try my best to be on time and give you a nice overview. Those are my disclosures, and those are the objectives. So first, we're going to gain knowledge about the global epidemiological status of severe acute hepatitis in children. We're going to try to understand the working hypothesis on etiology and the future direction. And third is to recognize the immune dysregulation phenotypes and the therapy on the horizon. Starting with the first objective and starting with a case, courtesy of Dr. Balesriri, this patient case was published in the Washington Post in May 2022. She presented on December 22nd, 2021 with jaundice and dark urine. She had severe hepatitis, as you see here from the transaminases, with cholestasis, coagulopathy. She had a comprehensive workup that was negative for non-etiology or severe hepatitis. So she was diagnosed with indeterminate acute liver failure. And then her clinical course progressed and she developed encephalopathy. The team tried high-dose salmeterol, but this did not result in improvement, and she underwent liver transplantation within 1 week of presentation. And I'm stressing the 1 week time frame because it's really important. Most of the patients with indeterminate acute liver failure would either need a transplant or either unfortunately die within this time frame. So it's really important to manage them quickly and efficiently. And this takes us to the acute severe hepatitis epidemic and the definition of probable case that was set by the WHO and the CDC. And those patients were mainly less than 16 years of age. They had severe hepatitis, and they had a comprehensive workup that ruled out the common causes, including viral hepatitis or non-metabolic or genetic causes. It's to be noted that mild cases might have been missed or not reported, and these patients did not have clear link to particular geographic area, common exposure to specific foods, medication, toxin, animals, or travel. And at that time, we couldn't blame it on COVID vaccine because most of them were not vaccinated. And at that point, studies started to emerge, and the first of them was by Luke et al. And JHAP in May 2022, where they reported on 191 cases from 15 countries, and they reported a striking increase in GI symptoms in these patients in addition to the jaundice and pale stool. Interestingly, 75% of the cases in England and 50% in Scotland were positive for the human adenovirus. And when subtyping was done, 18 of those children were positive for the human adenovirus subtype F41. After that, multiple case series were reported around the world. Here I'm going to highlight a couple. Those were published in the same issue of the New England Journal of Medicine in August 2022. The first was from Birmingham, Alabama, where 9 children met the case definition. All of them were less than 6 years of age. 8 of them were positive for the human adenovirus, and 5 of them for the subtype F41. 2 underwent liver transplantation. And the authors were kind of cautious in interpreting the data, and they reported the sequencing suggests that if human adenovirus was positive, this was not an outbreak driven by a single strain. In the same issue, also the group from Birmingham reported their case series of 44 patients who were less than 7 years of age. 27 of them were of the 30 who were tested were positive for adenovirus, and 6 underwent liver transplantation. Also, the authors were speculative, and they reported that the role of human adenovirus in the pathogenesis of this illness has not been established. So Dr. Carpenter, who we heard from a minute ago, wrote an editorial on the same issue trying to put the finding of these two studies into perspective. And his assessment was there was not completely convincing evidence that human adenovirus is the culprit. At least in the US, we did not see a huge epidemic of adenoviral hepatitis. And also on biopsy, we did not detect the virus by immunohistochemistry. And this F41 subtype has been known to cause gastroenteritis, but not necessarily acute severe hepatitis. So the speculation was that this human adenovirus F41 might be serving as an immunologic activator. And after that, we see multiple reports throughout the world. I'm showing here the one from Japan, where 139 cases were reported. And as you see, like April 27, 2022 is the period where mandatory reporting started. And since then, if you look, the incidence has declined significantly. The Japan group reported that only 3% of their cases required liver transplantation and none of them died. And the positivity rate of human adenovirus was relatively lower than other countries at 9%. And in July 2022, the WHO issued its report showing like the distribution of these cases across the world. Most of these cases you see were in North America and some in Europe, some in Japan. So it's a summary of the global situation and the first learning objective. By the end of August, we have seen 1,284 cases. And maybe you can use the pointer here showing that the peak of incidence in April and significant decline afterward. Most of the cases are from America and Europe. Gender distribution was roughly equal, and most of the cases were less than 6 years of age. Interestingly, there was only 4 who were epidemiology linked. They were kind of close contact exposure to a probable case. And GI symptoms remained the predominant symptoms. The outcome was a little bit better than what we see in acute hepatitis of indeterminate etiology. Only 5% required liver transplantation, while in patients with indeterminate acute liver failure, we see around 25% rate of liver transplantation, 2.4% died, and 27 required ICU admission. So this takes us to the next objective. So what's the working hypothesis on etiology? So since then, investigators around the world trying to make sense of what's going on, and this group from Germany published their data in Journal of Hepatology in 2023. They included 107 patients in a retrospective study from 2 centers in Germany. And as you see here in this pie chart, even since 1990, most of these patients, around like 56% were less than 6 years. So this is a disease of young children. Around 50% of them had GI symptoms. And the rate of adenovirus positivity was kind of low in the German study. Only 2% were positive. And they have like this nice graph showing the significant increase in incidence during the SARS-CoV-2 pandemic of this non-A through E hepatitis. Although this increase in incidence did not reflect an increase of liver transplantation or increase in mortality. And the author concluded that this rising incidence of these acute severe hepatitis of unknown etiology, what we used to refer to as non-A through E hepatitis, in the absence of significant increase in adenoviral infection, indicate other potential triggers, mainly immune dysregulation, basically. And then after that, we looked at the morbidity and mortality weekly report was published, and there was around 296 cases in the US. In the US, the adenovirus positivity was much higher, 40%. And 10% of these cases of acute severe hepatitis had SARS-CoV-2. Most of them had GI symptoms, and there was no identified common exposure. So, the following study tried to make sense of the clinical pathological feature of this severe acute hepatitis, and most of them are small center study. For example, this one of 11 patients, they tried to characterize the histological feature of the severe acute hepatitis, and some of these features are really similar to what we see in severe autoimmune hepatitis, with significant inflammatory infiltrate that's portal-based, and increased number of plasma cells, as you see here. There's some non-specific feature as well, some that's like hepatocyte necrosis and endotheliitis. And there was significant bile ductal proliferation, as you see here with cytokeratin 7. Interestingly, there is a report of increased macrophage activation with CD68 positivity, and occasionally, this hemophagocytic picture of activated Kupffer cell in the sinusoidal space was reported. So this study concluded that liver injury resembles severe autoimmune hepatitis and may represent an immune-mediated process associated with viral infection. So what's the cause or the working hypothesis? If we put all this information together, we might be dealing with a new agent, like a novel adenovirus variant, with or without a cofactor contribution. We're going to blame it on SARS-CoV-2 because this what happened during the pandemic, or it might be just because the host has abnormal susceptibility to this human adenovirus, either because of co-infection with another virus or priming by a prior viral infection like synergy, or maybe just lack of exposure during the COVID-19 pandemic, or maybe we're dealing with post-infection SARS-CoV-2 syndrome, the multi-system inflammatory syndrome in children, or MIS-C. So how we go about kind of making this clearer, people started thinking beyond adenovirus, because actually this adenovirus 41F subtype was detected in 3 cases, has similar sequence to circulating strains. So the theory of a new virus, of adenovirus, was kind of refuted. And we started thinking about the role of adeno-associated virus. And this color transmission electron microscopy is showing the adenovirus, and you see it's a huge virus compared to the smaller adeno-associated viruses. And those are thought to be helper virus, so they are replication defective. They need the presence of another virus like adeno or HHV6B to replicate. They're not known to be associated with the human disease, and they're used in gene therapy. But interestingly, most of these gene therapy protocols do include the use of salmeterol to prevent hepatotoxicity secondary to AAV2. And AAV2, unlike adenovirus, was detected in the explant. But still, it might be a bystander and not really part of a causal pathway. So things started to clarify since 3 groups independently implicated the infection by AAV2 in the unexplained acute hepatitis in children. There was 3 Nature papers published in the same issue in March 2023. And the 3 of them, they used untargeted approach, case control metagenomic next generation sequencing, and identified the same strain of AAV2 by phylogenetic analysis. The study from the UK, the rate of AAV2 positivity was 81% in the affected children versus the healthy children, and the liver biopsy in 5 of those did show the AAV2 virus by RNA site hybridization in the nucleus as well as the cytosol. And there was some interesting histological features of viral hepatitis. As you see, there was nuclear inclusion, swollen hepatocytes surrounded by T cell, suggesting a causal role. More interestingly, this group identified an MHC, class 2 HLA DRB1, O401 allele that usually predisposed to autoimmunity to be present in 93% of cases versus 16% of healthy children. And I just want to mention that HLA-DRB1 is expressed on the surface of the antigen-presenting cell. Actually, its function is to present peptide to the CD4 T cell or the helper T cell. So imagine that this protein is malfunctioning, this is going to result in an exuberant inflammatory response. Likewise, the other group from UK reported increased AAV2 positivity in cases up to 96%, and also increased number of other viral infections like HHCV, human herpes virus 6B. And the thought process is that these co-infections are enabling AAV2 replication and leading to liver injury. And the third Nature paper was from a group in the US, and the same story, they identified high AAV2 positivity, but as you see, the number of cases is relatively small, and they actually identified with co-infection with triple and quadruple virus, like common viruses that we see, including human adenovirus, EBV, HHV6, and enterovirus A71, and up to 75% of the cases. So they concluded that the severity is related to the co-infection of AAV2 with one or more helper virus, likely secondary to increased exposure as the SARS-CoV-2 pandemic was receding and lockdown was released. And Dr. Taki, Frank Taki is an immunologist and adult hepatologist. He wrote an editorial in the same issue of Nature trying to make sense of these three papers. And he arrived at the conclusion that we cannot really exclude the role of COVID-19 as a contributor factor to the severe acute hepatitis, because the timing of outbreak was really striking in relation of COVID-19. And I think the group of Germany have done a good job with their curve showing significant increase of incidence since 2019 of these cases. And the thought process that SARS-CoV-2 might be acting as a superintegen, triggering immune response to the human adenovirus F41 or even the AAV2. And this immune response is the damaging factor and responsible for this severe hepatitis. We have to take into consideration that children has been exposed to a large number of viruses after the lockdown, and they had a poorly trained immune system that might have contributed to this severe hepatitis. So in summary, the human adenovirus 41 is implicated in the etiology of acute hepatitis syndrome. There was high positivity of case, there was increased detection and temporal association between the fecal detection and the development of hepatitis. And also there was strong association between being positive and being a case in case control match study. And we have to remember the age range of this cohort, most of them were less than 6, correspond to the period of lockdown during COVID-19 and lack of exposure. And this delayed exposure to adenovirus may have triggered a dysregulated immune response, damaging the liver rather than causing a direct cytopathic effect on the liver. There might be a role for cofactor like the genetic predisposition with the HLA allele, or maybe co-infection with other viruses predisposed to this severe hepatitis. So what are the caveats and the ongoing investigation? So those studies you show were small studies, the number of liver were small, we did not have a lot of clinical information about those patients. Again, the adenovirus was not detected in any of these patients. And then, we have to take into consideration genetic susceptibility and also contribution from other viruses. And this is really important to inform therapy. Would we do immunosuppression or we use direct antiviral therapy? So that's why registry and clinical study have been developed in Europe and North America to better understand the cause and assess the outcome. And this takes us to our last objective, which is really an interesting topic, is the immune dysregulation phenotype and how we can treat that. So what has been known before about before this epidemic about the indeterminate pediatric acute liver failure? The number of around 30 to 50% of cases of acute liver failure in pediatric are of indeterminate etiology. This is based on the guideline we wrote in 2022. And liver biopsy, although the tissue is the issue and we find the answer most of the time, acute liver failure might not be very helpful because the pattern of injury is non-specific. You might see hepatocyte injury, necrosis, non-specific inflammation, as you see in this slide, histology, but some cholestasis, but really it doesn't give you a specific diagnosis. And the pediatric acute liver failure study group, this is a multi-centric study in the US, have tried to understand the indeterminate acute liver failure. In this report of 348 patients, they identified that the patient with indeterminate acute liver failure had the highest risk of requiring liver transplantation, like up to 46% did require liver transplantation. And 11% of them died without transplant. And interestingly, this next study of 872 patients, when they looked at the patient who underwent liver transplantation, the ones who were transplanted for indeterminate acute liver failure had higher late mortality after 1 year. And the mortality was mainly because of sepsis or multi-organ failure, and was thought maybe to be secondary to natural killer cell or T-cell dysfunction in this particular patient population. So this takes us to the concept of immune activation or dysregulation as a maladaptive immune-mediated liver injury. And this concept started to be more common in 2013 and 2014. This study among the first few studies that included 77 patients. It was a multi-centric study. 56% of those patients with indeterminate acute liver failure had immune activation stigmata. And immune activation is a term that's used loosely. So those patients might have cytopenia, marked elevation of serum ferritin, low or absent natural killer cell function, atypical perforin and granzyme B expression, elevated soluble IL-2 receptor, I think is the one the most studied, and they have elevated serum soluble CD163, which is a marker of macrophage activation, or decreased expression of the CD107 alpha, which is an NK cell surface marker of degranulation. So the author of this study reported that patients with acute liver failure and immune activation were at increased risk of requiring liver transplantation or dying within the first 3 weeks. And this risk of liver transplantation or death was proportionate or correlative with the height of the soluble IL-2 receptor. And a soluble IL-2 receptor over 5,000 was predictive of this risk. Interestingly, most of the patients who survived in this study with their native liver have received steroid during the study period. And the author concluded that if you have a patient with stigmata of immune dysregulation and you have ruled out an active infection, maybe it's reasonable to try high-dose solimedrol to try to help them recover and increase the chance of survival with the native liver. And actually, this immune dysregulation is also seen in patients with this severe seronegative hepatitis associated with aplastic anemia. This is a single-center study with a small number of patients, but they did a good job immunophenotyping these patients, and they showed the same kind of immune dysregulation stigmata that I've listed before, including increased soluble IL-2 receptor, ferritin, increased ferritin, low NK cell function. And they show dense infiltration with the cytotoxic T cell, CD8 positive T cell, as you see here with immunohistochemistry. The liver biopsy HNE stain was not very helpful. In this case, it shows significant severe hepatitis. But interestingly, those patients did respond to thymoglobulin, and thymoglobulin was effective in sustaining remission of both the hepatitis and the aplastic anemia. So, I spoke about immune dysregulation, but we know at the other extreme of immune dysregulation is HLH, or hemophagocytic lymphohistiocytosis, which is a rare multisystemic clinical pathological syndrome. It's like a cytokine storm, and there is intense inflammation. And acute liver failure may dominate the clinical picture or may present at the onset of HLH. And there are two main forms. The primary form, or the familiar form, it's a monogenic defect. There is a family history in some cases. And it's a genetic defect in the degranulation or the granule-mediated cytotoxic T cell and NK cell function. So there is a defect in this process of releasing the perforin and granzyme that's important for the NK cell and the cytotoxic T cell to kill the target cell. So you have this proliferation of T cells because this inflammatory response is really not productive, and activation of the macrophages. So the macrophage will engulf the hematopoietic progenitor cell and mature cell and give you this hemophagocytic histological feature. Remember, also HLH can be secondary or reactive, but you're going to need a trigger, and the most common one is EBV infection or viral infection. Rheumatological condition like macrophage activation syndrome can be a trigger, and as well as malignancy. And genetic causes of HLH can be identified in up to 80% of the cases. The familiar form, they're going to present early in life, and they're going to have a severe type of mutation like a classical frame shift or a nonsense mutation. But the secondary one also might have like single nucleotide polymorphism or sequence variants. And here I'm citing the diagnostic criteria of HLH. You have to fulfill 5 of those 8 to be consistent with HLH. But if you look at them, they are similar to what we see in immune dysregulation, but they are more extreme and more specific. And here I'm showing a liver histological section showing these activated Kupffer cells engulfing the hematopoietic cells. This goes back to the name of hemophagocytic lymphohistiocytosis. So going back, so people have been wondering like how you can say that this acute liver failure is because of immune dysregulation, and can we develop biomarkers to identify those patients who have immune dysregulation? This study had looked at a panel of 26 inflammatory mediator, and they identified an interferon gamma-related network as a discriminator between spontaneous survival and death. Also, other studies have looked at CD8 positive T cell, the cytotoxic T cell that we were just speaking about, and they've shown that the number or the density of infiltrate was much higher in patients who had the indeterminate acute liver failure compared to the patient who had determinate or known cause of acute liver failure versus patients who have just simple autoimmune hepatitis. And more recently, in an oral abstract from the liver meeting, there has been like advances in how we look at immune dysregulation, including using imaging mass cytometry. And this group from Los Angeles actually identified a specific signature. A patient with acute liver failure who recovered and had survival with native liver did have expansion of regulatory and PD-1 positive T cells. So the author concluded that immune exhaustion actually may mediate this inflammation and injury in acute liver failure. So summary of this component of the talk and ongoing investigation. So remember, the spectrum of immune dysregulation phenotype might be focal, might be like the form presented with autoimmune hepatitis or severe aplastic anemia. It might be multifocal when you see the patient with hepatitis with the aplastic anemia. It might be systemic, like the HLH patient or the macrophage activation syndrome patient. And patients with indeterminate acute liver failure may not meet the HLH criteria, but may fall within the spectrum and the spectrum might be potentially triggered by a viral illness. So immunosuppression in this setting could reestablish the balance between beneficial inflammation and harmful inflammation, because not every inflammation is bad. And this is really important to promote regeneration and increase the transplant-free survival. However, how we go about that, how we would know who is the patient who's going to benefit from immunosuppression, this is a question under investigation right now. There is a clinical trial going on in the US that's funded by the National Institute of Health, by the Pediatric and Acute Liver Failure Immune Response Network. The trial is called TRAMP, or Treatment for Immune-Mediated Pathophysiology, and they're looking for the efficacy of high-dose solumedrol versus thymoglobulin, in addition to supportive care alone. This is a placebo-controlled randomized clinical trial, and we are awaiting the result of the trial. We don't have, it's still ongoing. So this is pretty much everything I'd like to share with you. The Mayo Clinic during Christmas, this is the Plummer building, and we have this lighting pattern that shows the Christmas tree. And I welcome any question and discussion.